Hi everyone. Today's topic is aortic intervention tips and tricks by Dr. K. Murli, and this is live on the YouTube also. We'll start our PPT, our presentation in 5 minutes. Hi everyone. Today's topic is mostly people now go into the YouTube actually. Everyone's scared of Zoom. Zoom will hack their data.
So, Dr. Mulli, there are lots of attendees on the YouTube. So you will see only less attendees here. So don't feel there are less people.
They got scared of Zoom.
Yeah.
But YouTube, yes.
But YouTube, they can interact or
they can chat. They can send the questions and we can answer that.
Okay.
So Dr. Ajit will send you the questions and from the YouTube, and I think let's start.
Yes, sir.
You got 5 minutes more. Shall we?
Yeah, sure.
1 second. Yeah. Good evening, friends. At the outset, let me thank the ISVIR team for having asked me to talk on this webinar. What I will do in the next 30 minutes is I'll just share some of the tricks and tips in aortic interventions. And these will be a sort of basic stuff which I think we should follow in cath lab, and also show some cases where we had problems. I'm not showing you the good cases where we had problems, and I'll also tell you how we sorted it out and how important it is when we do the aortic work. Now, the last few days back when Dr. Roshan had presented, he talked to us exactly about the planning, how exactly planning is the most important thing in doing aortic interventions. The next important thing is when you plan aortic interventions, we have to go through certain fundamental steps. Number one is, where do you want to place the graft, the landing zone? If you take the Tripoli, you need a landing zone of at least 15 millimeters. We know that the company still, you can go up to 10, but safer thing is to take at least 15 millimeters. In the thoracic, the ideal will be 30 millimeters, but now we manage with 20 millimeters or even up to 15 millimeters. Let us take 15 as a sort of guideline, but you have a longer landing zone, better for the longevity. When you treat thoracic aneurysms, always go for a 20 or a 30 millimeter landing zone if it is available. Second thing is sizing of the graft. How much you should oversize. We talked about how to size the aorta in the last lecture. When we look at oversizing, we look at a 20% oversizing for aneurysms. And if you're going to treat dissections, you take an oversizing of around 10%. Don't exceed it. What are all the materials you need in cath lab? See, aortic intervention, you need to have the entire armamentarium in your cath lab. Otherwise, don't try doing it. For example, all these things, many of things might look stupid, but it is better to have it because you may never know in which case you will require it. The first thing is you have a dilator set up to 20 French at least. We know the grafts are 20 or 22 French or 18 French. You have dilator set, we have dilator set up to 24 French available. Guide wires. See that you always have hydrophilic guide wire, both the angled and the straight ones. For exchange length, preferably we use a Lindequist because the graft easily tracks over it. Or if it is not available, you have a ultra stiff Amplatz wire. The catheters. The ideal thing you need is a marker pigtail because that helps in giving all details. The other catheters which you should have is a Judkins right, a Cobra catheter, a vertebral curve, SIM, RDC, etc. So don't search for a catheter because when you do a Tripoli, sometimes to cross from the opposite gate, it becomes tougher. Then you may have to keep changing the catheters. So it is better to have all the catheters. When you do a dissection case, sometimes we may have to use a guide catheter because you may not know whether you are in the true lumen or false lumen. You want to inject contrast. So best thing is to have a guide catheter, a RCA guide, a 5 French or 6 French, and you can give a gentle whiff of contrast and you can see where you are and you can keep on pushing your catheter. The most important thing is always have a snare. This is very, very important when you treat large abdominal aortic aneurysms. In such a situation, you may not be able to cross the gate. Suppose the gate if the other limb opens up in some other different direction, it becomes very tough to cross from below. In that case, sometimes you have to come from above. And when you come from above, it is better to have a snare so that you can snare the guide wire. When you do a fenestration or branch cases or chimney cases, you need more material. One is the longer sheets for the fenestrations. The next important thing is look at the length of the sheet. You will tell, I want the sheet. Suddenly, you will need a 100 centimeter long sheet and you'll have 80 centimeter long sheet in your shelf. It's very important you check all the sheets which are available. We need this intermediate guide wire called as Rosen guide wire, especially when you want to put a stent into branches. This is a very good guide wire. Always have backup micro catheters, micro wires. Then from the hook, we have these catheters called CX35 and CX18. These are all very, very important because they navigate much better. And you always have own white wires and own 4 wires. And when you do these fenestration branch cases, you also have the micropuncture sets ready with you. Because anything if you miss, then you'll start struggling. So what is the axis you'll use? We always use the femoral. It's up to you to decide whether you want to use a percutaneous or a surgical cut down. People who are beginners, it is better to go for a surgical cut down because it is much more better. Controlling is much better. Don't straight away go for a percutaneous access unless you get a lot of experience. Yes, you can do a percutaneous access also, but surgical cut down is always better. And you always prefer to have a brachial or radial access in almost all the cases. This is just to see that sometimes you're not able to come from below, you have to come from above. When you deploy a graft, the next important thing is always be very precise. We always think that we can push the graft or pull the graft, we can recapture. Don't do all these tricks like how you do in your peripheral work. Always be very precise. Do not push or pull too much. You go through whichever stent graft you're using, follow all the steps precisely. You rehearse the steps multiple times and make a complete mental picture so that when you do the procedure, you don't make any mistake. The next important thing is in thoracic, when you want to deploy, one of the things across the arch, the stent can slip back. There you need a complete control on the graft. Suppose you're not very confident, you feel the angle is going to be very acute. The alternate thing which you can do is get the BP down by doing either a rapid pacing or you can keep a balloon in IBC inflated so that the IBC, by inflating the balloon, the blood pressure will come down and you will be able to deploy the graft without much problem. But in our experience, people who are doing most of the thoracic work, especially across the arch, we have never faced this problem because you have to be very, very careful in deployment. But on the other hand, if you're going to put in grafts in the ascending, it is better to have this as a backup technique for you, because in ascending, you need to be more precise, you have to be perfect. Now, I'll just show the cartoons, which basically the company cartoon, when you do a Tripoli. So once you cross it, this is the graft which is coming up, and you're going to deploy it. So when you deploy it, you see that you're always below the renal levels. You start deploying till you have the opposite gate. Then you have to cannulate the opposite limb. Then you deploy the top end. Then you finish the things by putting in the limbs. So this is going to be common for any graft you use, whether you use the Medtronic or the Cook or the Anaconda. It's all just the common things. Maybe you have a 3-piece system in Cook. The newer Medtronic ones are also going to come with the 3-piece device. Otherwise, the conventional Medtronic device, it's a 2-piece system. So you have to know which one you are using and do it. So once you finish the procedure, we always try to balloon a few areas. One is at the top end, then where exactly the junction is, and also at the distal end, so that you try to oppose these ends to the artery, so that you want an endoleak. So you can see here, these are all some of the steps which are critical. I just put in so that this is only for the demo. This is the renal vessel. Usually we don't do a roadmap and all, but we always mark where the renal artery is. And you can see here, you start deploying the graft by very, very gently. As you start coming down, the graft will try to move. You have to control it perfectly. And you can see here, be very gentle. There is nothing to hurry. You can go slowly. And if you want to just move a little bit, you can move a few millimeters and you can deploy the graft. And you can see here, once the graft is deployed, you cross it with a catheter, or you can release the top end also. So this step you can interchange. Either you can release the top end first, or you can cross it and then release it. So you can see that this is the top end which is getting released. So that is at the end. So in the Medtronic, there is a different system. In the Cook, there is a different system. Just follow it. You just deploy it here. You can see here, the graft is deployed. So this is the bare portion of the stent graft, and this is the covered portion, and it is definitely the renal artery is not compromised. So this is in thoracic. And when you do these techniques, you keep these injections, always check that you have not covered these vessels. In the thoracic also, it is almost similar. You just deploy the same thing, and you're going to deploy the top end at the end. So I just want to show the sort of movement which you should have. You can see here, you just go very gently, do it millimeter by millimeter. In fact, you want to check injections, you can always do in between. And the marker pigtail should be loaded with contrast always, and use the adequate dose. And you can see here, you don't need to panic at all. You just go in a single movement and you can deploy it. And the deployment techniques might be slightly different for different companies. So you just follow the same technique what you're going to use. This is a Cook device where we are opening the top end at the end. This is in the thoracic. The next important thing is certain other things. The spinal protection. When you cover a large segment of the thoracic aorta, the most important thing for spinal protection is when you do the procedure, see that the patient does not have any hypotension. You have to inform the anesthetist and see that they give the fluids optimally, and see that the blood pressure is maintained at a good level. If you want to do a CSF drainage, discuss with the anesthetist first and decide. CSF drainage we use when we cover a large segment of the aorta, especially when we do a fenestrated thoracoabdominal or procedures like that. And you go as per the protocol. The next important thing is do not cover the branches just like that. Especially the left subclavian artery, if you can preserve it, it is much better. Interiliac artery, don't cover. In case you have to cover the left subclavian artery, always think whether I need to do a left subclavian bypass or do a fenestrated procedure in this patient. Anesthesia. In the thoracic, I would prefer always to do it under general anesthesia, because the patient can never cooperate in breath holding. So you need a complete breath hold. It is better to do it under general anesthesia. In AAA, you can do it under spinal. Invasive BP monitoring is a must. You have to look at the blood loss, how much you have lost blood. Urine output, ask the anesthetic to monitor. Heparinization, yes, you start with the standard 2,500 or 5,000 units as per your protocol. And if your procedure is beyond 1 hour, just strip up the heparin, or you check the ACT and give heparin. The last one is a little controversial one, the role of IV methylprednisolone. Again, there are some groups which use this to prevent a graft versus a host reaction. And it is said that when you use IV methylprednisolone, definitely the chances of fevers is very less. But off late, we don't see this even without IV methylprednisolone. Now, let us go to the cases. Now, let me show this patient. This looks like a very straightforward case, a straightforward Tripoli, except for some calcium here. Yes, on a visual appearance, you look, everything is okay. Don't believe the pictures. You do the measurement yourself. You can see here, when you do the measurement, you see the distal aorta. It is only 15 millimeters. If you want both the limbs to open, you need at least 18 millimeters of the distal aorta. If it is less than 18, if you are going to open, you will definitely get into trouble. So this is very, very important. The pictures alone will not provide all the details. You have to take the measurement yourself and then decide what to do. So this was very small. You can see on the aortogram injection also, it is definitely less than 20 millimeters. So we decided to do a aortounileg stent graft and follow it up with a femorofemoral stent graft, femorofemoral surgical bypass, and a plug was put in. So this is the easiest technique which can be done to tackle this case. Now, a technical note. You may not get straightforward cases always. You can see here, this patient has got a AAA. Looks like it's a doable case, except there is a cranial angulation. I think last week, in the last lecture, we had discussed about the ankles, and this is still a doable case. And when you see the sagittal reconstruction, there is a fairly good neck, though it is anteroposteriorly aligned. It is still doable. But once you come to the cath lab, you see the AP view. You hardly see the neck at all. But when you do a cranial angulation, you will see the neck very clearly. So how to do it is, when you do the CT, you do the reconstruction, you make all the pictures ready, you mark the angles and come to the cath lab fully prepared. In which angle you want to do, which ankle you want to deploy, where do you see the left renal artery. The CT gives all the details. All you need is to take a couple of shots in that particular position. And this procedure was done after doing this cranial angulation. The graft was placed. Now, in this case, you can see here the aneurysm starts here. There is hardly any space. This guy came with a leaking aneurysm. This was a couple of years back. Leaking aneurysm, a very old man, and hardly any space. So as an emergency, we went for a Chimney procedure. You can see here, we pushed the graft up. At the same time, by both the brachials, we had accessed both the renal arteries. We had placed additional stent grafts, and the the endovascular graft and the renal grafts were deployed. And this is the final picture. The renal flow is preserved. And the most ideal thing for a patient whose neck is inadequate is to go for a fenestrated procedure. You can either do a on-table fenestration. The preferable thing is to do a 1 or 2 facial fenestration. If it is more than 2 or 3, better to order a fenestrated stent graft, which is better. But if your experience is good, then you can go for multivessel fenestration. This is one such patient where we have done a multivessel fenestration in this patient to improve the landing zone, because there was hardly any landing zone. So we had to put in catheter with stents into superior mesenteric and the renals. Now, in a thoracic aorta, if you see a huge aneurysm like this, how many stents you will prefer? Because the company guys are today going to come and tell you, I have a 250 centimeter graft, long graft. I have a 220, I have a 230. We'll always be tempted to use a single graft. But please understand, when you have huge aneurysms, yes, you can get away on the day with a single graft, but when you put in a single device, sometimes what happens, migrations do occur. So when you see a large aneurysm extending for a longer leg, always put in 2 devices. When you want to put 2 devices, which device to take first? You can see that this aorta is narrow, measure it, take the distal device first, and through that take the proximal device. That will be better. And you have to be very, very perfect in measuring so that you don't have any problems when you put these devices. So this was done here. This is a 1-year follow-up CT angiogram. Absolutely fine. Now, what happens is in our country, because of the cost involved, we try to conserve. So this is one such patient. We thought it was hardly around 12 centimeter. We'll use a 20 centimeter graft. We'll get a good landing zone of almost 4 centimeter on either side. and we finished the procedure. Everything was good. You see what happens. We are all worried only about the proximal migration. But please understand, in large aneurysms, distal migration also can occur. What happened in the first 3 months follow-up, the stent had got pulled up. After a few months, then the aneurysm started enlarging. So we had to come and complete it with another device and finish the sealing. So it's very, very important. Probably I thought retrospectively, if you had decided on 2 grafts in the initial stage itself, this would have been much better off. So it's very, very important. You have to analyze the pictures very clearly and decide whether you want a single device or 2 devices. This is another patient. She was a young lady, a 25-year-old lady, who kept on complaining that she had a cesarean section. After the cesarean section, she developed severe back pain. After delivery, she came. And because of the back pain, they were not sure what it was. Once they did an abdominal ultrasound, they picked up this abnormality. Then a CT was done. This aneurysm was picked up. So you can see here, this is an aneurysm here in a very young girl who did not want open surgery. Left alone, we would advise open surgery for this girl. But since she did not want, she insisted on endovascular, we decided to come in. So you can see here, when we wanted to place the graft, we know that the neck is somewhere here, and we have to cover the celiac artery. In a young girl, I didn't want to take a chance. So what we did was we put a balloon into the celiac and injected the SMA just to demonstrate we don't compromise on the hepatic circulation. And we thought this will be fine. So we decided to place the graft and covered the celiac. And when we did the procedure, we always had a catheter in the superior mesenteric artery. This is very, very important because you should graft should never come below that. You should never cover the superior mesenteric artery. And in case you cover, you be ready for a reverse chimney. So with these things in mind, we kept a catheter in the superior mesenteric artery, just placed the graft and deployed the graft in the thoracic aorta. And you can see here, this is a 1-year follow-up. The aneurysm is treated completely without any problems. And superior mesenteric flow is good, and the celiac flow also was good. Sometimes we have to take decisions based on the clinical condition. This is one patient, a complicated type B dissection, comes to the hospital on a Saturday night at 11 o'clock. So we saw these images. We thought the ideal thing will be to do a hybrid procedure, maybe do an arch hybrid and follow it with an endovascular graft. And by the time we planned everything, took the measurements, we thought we'll do it on Monday. On Sunday morning, this patient, we went to the hospital to see the patient. At that time, the patient collapsed right in front of us. We did not want to waste much time. It was a rupture. So pushed him straight into the cath lab. Since we had the device, we started deploying. And you can see here the deployment starts at the right place. We just pull it back. And this patient was very sick. And we were doing it at a rapid pace. You can see here, we just went in and deployed the graft. At the end of the deployment, we could not control it perfectly. And the graft had just come, slipped a little bit back. But the aneurysm, the dissected portion was completely covered. It was perfectly fine. Then a chest tube was placed. A lot of blood was drained. The patient became fine. And we did a check CT at the end of 10 days before discharge. Everything looks fine. The graft had slipped further below, but everything was looking okay. We see the residual dissection distally. That's fine. But the most important is see at 3 months. We know that the sealing zone was not good. When you look at the initial picture, we hardly had a sealing zone. We had just started from here, hardly 7 or 8 millimeters. Still, we couldn't control it well. And this is what happened. At 3 months, the whole thing had recurred here. It has become aneurysm. So this time, it was done an elective procedure. The ascending aorta was replaced, and grafts were placed to both carotids. And we completed the procedure, placing an additional stent graft to the existing one. This patient is still on follow-up. It's almost now 11 years. He's doing well. We have not done anything for the thoracic, for the abdominal portion. Here is another guy with a huge aneurysm, symptomatic. He was a 75-year-old gentleman, not fit for open surgery, and has this distal thoracic aneurysm with an aberrant subclavian artery, which was aneurysm. So the most important thing is, you can see here, we have a neck of almost 3.6 centimeters from the aneurysm by covering the subclavian. So we decided to do a bilateral carotid subclavian bypasses, which was done in this case. Bilateral carotid subclavian bypass was done, and we thought we'll place a graft from here. And we did not want to do a sternotomy because he was a very old gentleman. He had a lot of other comorbidities. So we decided to go as minimally invasive possible without doing a sternotomy. But what happens? This is the picture in the cath lab. We do multiple views. We still do not know where exactly the other vessels are coming from, because the aneurysm is huge. We cannot really find out. You can see this is the left carotid, and we know by the CT we can place it here, but still we were not convinced. So luckily, since the surgeon had already done a carotid subclavian bypass, we passed a guide wire from the subclavian, came into the carotid, kept an additional stent, which was a stent was placed as a Chimney procedure, and this endovascular graft was placed, and the procedure was done. And everything was fine, and the patient woke up without any problems. And we did a check CT. We were possibly perfect, but in the cath lab, we were not sure where we are going to land the graft. So when you have a doubt like that, it's always better to plan a chimney and keep things ready. So that's why this brachial access, you can see here from the subclavian, we went into the carotid, came through and placed this graft, and this aneurysm was treated by this procedure. Again, in acute type B dissections, sometimes it is very, very tough to navigate the guide wire. The reason is I'll show you on this axial view. We cannot even tell which is the true, which is the false. It's all just lying in pieces. You can see here, this is the huge false lumen. We do not know whether this is true or whether this is true. And you come here, this is like this. So this patient, you can see here, it's all lying like this at the celiac level. And it's very, very important you go through all the axial images very carefully, make a mental picture of how the true lumen goes, how the false lumen goes. But what helps you in the cath lab is to have a transesophageal echo with a TE probe. So you can, most of the anesthetists today, the cardiac anesthetists are very good. They'll show you the wires perfectly, the true and the false lumen. In addition to a fluoroscopy, you can use the, so you can see here, we came from below. We can see the true lumen, which was starting here. We got into the true lumen, gently progressed the catheter. Then you can see here what happens. The moment we put the catheter here, and these are the two positions of catheters. This portion of catheter is in the true lumen, this is in the false lumen. This we can never know in the fluoroscopy. But on the TE, it was very clear. The other one was the false lumen, this was the true lumen. So you have to be very, very careful in navigating the wire. You use all the techniques which you have, either a fluoroscopy, then you use your transesophageal probe, and this was sorted out with the TE probe. And then finally we got the wire inside the true lumen. And this patient basically had the ascending aorta replaced with arch debranching done. We took the patient the next day for this treatment. So you can see here, this is the injection. The whole false lumen is filling up. And this injection, you can see it is basically catheters in the true lumen. And as we start placing the graft, you can see here we place the graft, and what happens is the graft swings right into the false lumen. You can see the end of the graft is not in the true lumen, it swung into the false lumen. No need to panic. We know that on the injection, we still have the wire through the true lumen. We are completely in the true lumen. All we need is to add a graft. We know that we have to put 2 stent grafts in this case because we are starting somewhere from the ascending aorta. The first 20 centimeter graft was here. We have to place come up to the descending thoracic. So the second graft was opened up, and this is the injection which shows the graft is not there. Then we place the second graft inside. You can see here after the second graft is placed inside. Here when it is in the false lumen, how it pulsates, and you will see here as it comes into the true lumen how exactly it molds to the true lumen. So you can see here, this is now very well within the true lumen. So it's very, very important. You cannot afford to make any mistakes. We think it is an easy case. It is not always. When the true and false lumen is dissected very badly. And this is the final picture. You can see here, there is a good flow within the true lumen. Now, this is another patient. So I'm just going to introduce with cases to get some details how we are treating. This is a 61 male, a type B dissection with ulcer. Conservatively, he was manic. He was doing very well. This is the first CT. There was some type B dissection. Yes, it was looking fine. He did not have any complications like a renal or a mesenteric or a limb ischemia. His pain settled. He was absolutely all right. But as per our protocol, we always do a yearly follow-up CT scan at 6 weeks. When you did the 6-week follow-up, you can see that the ulcer has become very large. See, any instability in the first 6 weeks is an indication for you to intervene early. And dissections, when you do at 6 weeks, it is always good because you'll be able to get a very good remodeling. So once we saw this ulcer had enlarged significantly, we decided to do a stent graft, and which was done in this patient. So when do we treat dissections? We treat all complicated dissections when they're acute. What I mean by complicated is uncontrolled hypertension in spite of multiple drugs. If the patient shows an organ malperfusion, whether it is visceral, renal, spinal, or limb, if there is increase in periaortic hematoma, suppose you admit a patient, he keeps on complaining of pain, and you keep seeing the hematoma is increasing, then you know it is you have to treat them. Or if the patient has got a hemorrhagic effusion, then also they need to be treated. So in acute dissection, we always treat when the patient is hemodynamically unstable, when they have malperfusions or increasing periaortic hematoma. Otherwise, we can keep them conservatively, wait for 6 weeks and then do it. Again, if you do an early scan, if you see instability, when sometimes what will happen, the false lumen will start enlarging rapidly. They'll all be shown very early, even at 6 weeks itself. There are a lot of landmark papers on this. A lot of recommendations have come through. So you do an early scan. If the expanding aortic diameter is more than 4 millimeters, then it is an indication. If you see a new onset, everything is safe. In chronic, the next important thing is, suppose you have a type B dissection, you keep following him up. One of the things to intervene is if the aortic aneurysmal dilatation is more than 5.5 centimeters, or if there is an yearly increase of more than 4 millimeters, then you have to intervene in these patients. So the take-home message in dissection is, you intervene in all complicated dissections. In stable dissections, whether you can do an elective TEVAR or not. Yes, there are a lot of papers which suggest that we can do it. And if you're going to do it, don't do it in the acute phase if the patient is stable. Bring him back after 2 months or after 6 weeks, you can do it so that you can. Why we can do it is because of this. Your medical management delays your aortic expansion, but the aorta does not remodel. If you put in your stent graft early, if you're able to, approximate the true lumen and false lumen early, the aortic remodeling is much better. On the other hand, if you wait for a lot of years, the aortic remodeling does not occur. And once the aortic diameter reaches 55 millimeters, it ruptures. This we are seeing more and more with type A dissections who have had surgeries, and also in type B dissection. These are all some of those illustrated cases. Type B dissection, clinical follow-up for 7 years, in between CT scan, fine. Now what happened is he developed chest pain and increasing false lumen size. He also was a heavy smoker. He had severe COPD. See what happens. Patient is doing well, but you see the true lumen is hardly anything. Huge aneurysmal dilatation of false lumen. And how to deal with them. Chronic dissections, they are not very easy. Even if you put a stent, how much of true lumen opening will be there, you can never predict. So in that such a patient, many times we decide about surgery. If the patient is not fit for surgery, then we go for intervention, which was done in this patient. He had neck bypasses. He also had one carotid which was occluded, and we did a carotid subclavian bypass, and a stent graft was done, which was done here. And this is the final result. This is another patient. He was a young gentleman, 40 years. He was a gymnast and a heavy mountain climber. This guy developed a type B dissection. He was kept on conservative management. He was followed up very meticulously. And this is after 6 years. You can see here, he had this huge aneurysmal dilatation, and you hardly see the true and false here. And the true lumen is absolutely narrow. Otherwise, he was a fit guy for open surgery. So you have to be very careful. Suppose you want to put a stent graft. Yes, we can put a stent graft from here up to here. Then what about the rest of the portions? Maybe we'll have to do a second procedure. We may have to do a fenestrated device in a guy who is 45 years. So this patient was taken up for surgery. And you can see here the surgical result. This is a follow-up angio after 1 year. The whole aorta was replaced with a graft. The spinal intercostal arteries were attached as much as possible. The celiac, the superior mesenteric, all renals were reattached. I think this guy did not have one renal, if I remember right. So he did well with this procedure. Now our concept has changed. Yes, nowadays we don't, we go for a complete cure in most of these patients. For example, if you have complex type B, we know that you don't have a landing zone. You have to come into the ascending. That means you have to do ascending aorta. You have to do ascending aorta bypasses to both the carotids and the carotid subclavian bypass. So now with the newly available frozen elephant trunk grafts, it is more easier. but we'll have to first pass a guide wire here. Then this graft comes as two parts. The surgical graft is stitched to the endovascular graft, and which can be deployed antegrade from the ascending aorta, which you deploy, and the surgeon reattaches all the arch vessels. There are two grafts available. One is from the Thermo company, and the other is the Jotec, which has this grafts. So one of these grafts can be done, and the frozen elephant trunk. You can see here another patient, a type A dissection operated almost 20 years back. He comes with a huge aneurysmal dissection of the arch and a residual dissection. So this patient, he was redone a sternotomy. The same procedure was done. This is all the surgical graft, and this is the endovascular graft. Since the coverage was not enough, we took him for another procedure in the cath lab and added another stent graft after a few days after the first one, so that we treated most of the aneurysm very well. And this patient is doing very well. So dissections are something which needs a lifelong follow-up. It is not something I do a procedure, I forget about it. And I see a good result on table, everything is fine, but you have to meticulously follow it up. This is another such patient. This patient had a stent grafting done elsewhere, and they did not do a follow-up CT for 4 years. Every time the patient went, they told you are perfectly all right. Nothing needs to be done. He came with severe back pain. When he came to us, he did not have the old CT. He just had the angio CD. And this is the picture, the repeat CT scan. You can see this. This area is treated. This area has become aneurysmal. It is absolutely very bad. The aorta is huge, and we have to. And he is very symptomatic. He was about to rupture, and he was having severe pain when he was admitted to the hospital. It was not easy. It took a lot of time for us to get a guide wire. We thought of multiple things. We thought of we'll even have a guide wire from the ascending aorta. We'll snare it down, or we'll pass a guide wire from below. So after a lot of struggle, we got the guide wire across, and we placed a stent graft. The first stent graft was placed into the existing stent, which was not enough. We placed a second stent graft so that we thought we'll cover almost up to the celiac region. And this was done. This is the first follow-up scan. Everything was looking fine, but I was not very happy. We know that there is a lot of problem for us on the day to push and pull. I thought the second graft could have started somewhere here. It had just landed here, but still it had almost had overlap of 3 stents. Looking fine, I thought, but anyhow, we thought we'll do a early follow-up, and that is what happened. As expected, the graft has got displaced, the aneurysm kept on enlarging, and you see here both the grafts are got separated out, and you see this huge recurrence of the aneurysm. So we had to do a third procedure in him, went through that and put in a long stent graft, and then we finished the procedure. So we started from the previous graft itself. We really put a very long graft and finished the procedure, and this is the final result. So we have to be very, very careful when following up these patients. I think doing a dissection is not very easy. Please understand, dissection is a disease which involves the entire aorta. We all think we just need to cover the entry point, it will be all right. Yes, it will be all right at that point. The re-entry zones has to be carefully addressed, cover as much as possible. Then follow these patients meticulously and plan it in such a way. Tomorrow in future, you want to do endovascular, what graft you want to place, how to treat it. There are a lot of concepts coming up, like the petticoat concept, where you can place multiple bare stents. I don't have much experience in that. There is a lot of literature experience on that. And the most important thing is, the key is, if the aortic remodeling is very good, then the dissection patients do fairly very well. I think with this, I've shown most of the cases. So what I want to convey here is, number one is, you look at the CT scan very carefully. Most of your endovascular work is done in your CT room. It's more of a mental game. Look at all the measurements, take time, analyze yourself on the workstation. If you can do it in the CT room, it is okay. Otherwise, you can have the softwares in your laptop, go through everything, note down each and every point, note down the measurements yourself. Yes, the company people also will help you by taking the CD, but please understand, many of the company guys will not be strong enough to tell, sir, please don't do this or please don't do that. They'll just nod their heads for whatever you tell. So you discuss with your colleagues, you discuss the case very well. The next important thing is what materials you want. You arrange all the materials, make a list. And the third important thing is, This is not a procedure you're going to do day in and day out. You might get a case once a month, sometimes a couple of cases in a month. Suddenly you cannot do cases for 2 months. Then you have a flurry of cases for a few days. So you might forget the steps. Before doing every procedure, please rehearse all the steps. If you're using the Medtronic, know what are all the steps you want to do. If you're using the Cook device, please understand what steps you want to do. Make a mental picture, rehearse everything. Think of all the complications which can occur. Just find out whether you have the material for everything and then plan it. And when you do the procedure, see that you have got a very good landing zone, both proximally and distally. You're not, see that you have covered all the areas very well. And at the end of the procedure, see that there are no complications. Do meticulously all the injections, check all these things. But the most important thing is cath lab injections might miss something. The important key is to do a follow-up CT scan. As per your institutional follow-up, there are some people who do a follow-up at the time of discharge. There are some people who call the patient to an early follow-up at 1 month. So you do one of the two things. An early follow-up is very essential. After that, you can follow him up once a year or once in 2 years, whatever it is. So it's very, very important. Be very careful. When you treat dissections, please understand where is the entry point. Where all the multiple re-entry points are there. Where is the true lumen? Where is the false lumen? When you pass the guide wire, is my guide wire always in the true lumen? Keep on asking that questions. Take your time, put the wires perfectly, and then do the procedure. If you're not very careful, you'll get into complications. And if you want to avoid complications, do meticulous follow-up. Thank you very much. I think with this, I end my presentation.
Thank you, Murli. Yeah. Thanks a lot. Good, comprehensive presentation. I would like you to answer the questions that are there. But before that,
okay,
just want you to elaborate and tell them that which are the patients you decide to do, say for instance, an IVA. Which patients would you like to do a chimney, and which patient you would say chimney is not the good option and do a fenestration?
Yeah. Number one is when you look at the literature result, when you compare the fenestration with the chimney, the fenestration results are much better on a long-term basis. So as far as possible, try to avoid chimney. Then when we do chimneys, it is done as a bailout procedure. Somebody comes with a leaking aneurysm, where you don't have time to order your fenestrated graft, or you feel your fenestration, you're not very confident, you cannot make all the holes perfectly. In such a situation, straight away go for a chimney procedure. So chimney procedure is to be used only for emergencies and as a bailout procedure. For everything else, I think I'll go for a fenestrated.
Would you decide also on how far away the aneurysm starts from the renals to decide that?
Definitely. So the thing is, if any juxtarenal aneurysm, you need a good landing zone at least 2 centimeters above. So in such a situation, I think you ought to be very, very meticulous in planning. Suppose you want to, if the thing is very flush with the renal arteries, I'll straight away go for a fenestration. Because when you do a chimney, you have to put a very long, you will have 1.5 centimeters of the covered graft above. Then you have the bare stent. Then you have to put a real long renal stent also in the chimney. These long renal stents might get kinked. These are all balloon expandable. They may not do very well. So when you are going to cover a very large area, better don't do a chimney.
I think you could start with the questions.
Yeah. I can see it here. Or
the first question is, how common is spinal anesthesia, and when 2 devices are placed? Sorry, not spinal anesthesia. How common is spinal ischemia when 2 devices are placed?
Yeah, it is very fortunate for the endovascular group. In fact, we hardly see spinal ischemia in our series. In fact, in the last, when you look at the literature, the surgical risk is around 5 to 6%. The endovascular risk is around 2 to 3%. So this is the usual risk of spinal ischemia. So initially people thought, since I'm going to cover a lot of area, I'm going to develop spinal ischemia. But then the guidelines have come very, very clearly. Number one is maintenance of the blood pressure. When you put the patient on GA, the blood pressure crashes some instances. So the anesthetist should understand you should not crash the blood pressure at all. Number two is if you are going to cover the subclavian, suppose I want to put a graft starting from the subclavian onwards, I'm going to come up to the celiac level, then the risk of spinal ischemia is very high. I would prefer not to cover the left subclavian artery. If I'm going to cover it, I'll always ask for a carotid subclavian bypass or do a fenestrated for the left subclavian artery. So the left subclavian should not be covered. I think if we follow this principle, the risk of spinal ischemia is very negligible. Still, if you have a doubt, if your team is good, you can always put a spinal drain. You always put the spinal drain the previous day of the procedure. And you can always measure the pressure when you do the stent graft. They can always check up. If the pressure is very high, they can let out some CSF and they can spinal drain can be removed after 24 or 48 hours. So I think we have to follow these principles. But now we have a recent paper which tells that we are overdoing the spinal drainages, especially this came from people who are doing extensive thoracoabdominal work, especially fenestrated devices. But again, the risk is very, very less for us in the endovascular compared to surgical.
So the second question you have answered already in this answer, which was if you decide to deploy 2 stent grafts, do you get spinal drainage done pre-operatively and keep it in situ while procedure is going?
No, we don't. We don't do it as a routine. We do it when we cover the left subclavian artery also. Though we would have done a left subclavian to carotid bypass, then we do it. Otherwise, if you are putting in a single stent graft of around 20 centimeters, you don't do it as a routine procedure. We don't do it as a routine. Yeah.
What is the rate of drainage?
And another thing is what we do is nowadays we extubate the patients immediately and check their how the neurological thing is. Then we put in the drain. See, there are as far as the drainage is concerned, there are different schools of thought. I think we have to go through these papers. The cardiac anesthetists are very good because in our setup, they do a lot of thoracoabdominal open surgeries also where they do a spinal as a routine. So what they do is they look at the pressure. If the pressure is very high, then they let out around 10 ml till the end of the procedure. Then every hour they remove a few milliliters. So we leave it to them to handle the whole thing. So what they do is they let out a few ml every hour for the first 24 hours. Keep checking the patient's neurological status.
Okay,
it is not a continuous drainage.
There's another question. Sir, how much of overlap should we be made when deploying double stent grafts?
Yeah, there should be overlap of 3 stents.
Minimum.
It is minimum, yes. Especially in thoracic, I feel. Sometimes what happens is to cut down the cost. Whenever we have deployed only with 2 stent overlap, we have faced problems. 2 stent overlap in any device is almost 4 centimeter overlap. Even that doesn't seem to be good enough. I think when you want to overlap, better safest thing is to use at least 3 stents. If 3 stents is not possible, at least keep it up to 2.5 or 2 stents. Don't go below that. 3 stents I feel is mandatory.
Okay. There is another question. Who does subclavian carotid bypass and when?
See, it is, I work with the cardiothoracic team which does aortic work and they do the procedure. So the procedure is done the previous day, the carotid subclavian bypass. We take the cadavers procedure the next day. We don't do it on the same day and ship them to the cath lab. So we always do it one day before and take the patient for the procedure the next day. So it is done by the cardiothoracic surgeons. Yeah.
Then next question is, can you share a couple of cases of endoleaks and management? I think that we will take as a separate
thing, I think.
Yeah, because you cannot do this and that together.
Correct. Yeah.
Then there is another question, sir. What's your protocol for IMH?
Okay. So IMH. In IMH, number one is, again, you look at whether it's a type A or type B. Whether the intramural hematoma starts from the ascending aorta or it is only the descending thoracic aorta. If it is from the ascending, you always go for early treatment, like how you do a type A dissection. It goes for a surgical replacement ascending aorta, then decide whether you want to put an endovascular graft in the descending thoracic. If it is in the descending thoracic, it's like a type B IMH. Then what you do is you follow them meticulously, do a early follow-up scan at 6 weeks. What happens is many of the IMH will have a small ulcer, which we may not have picked up, or there will be a small dissection which we will not be seen at 6 weeks, or when you do a scan after 6 months, these things will come up. If there is instability, if the IMH size is increasing, or if there is an aneurysm, or the ulcer enlarges, then we treat them. If the IMH disappears, then we don't need to do anything. So you have to meticulously follow up a type B IMH like a type B dissection.
Do you give antiplatelets after aortic stent grafts?
No, it is not a routine, but many patients with an aortic disease will also have diabetes, coronary artery disease, or hypertension. If they are on antiplatelets for that purpose, we continue them. We don't start an antiplatelet only for an aortic stenting, but we use antiplatelets in case we do a fenestrated device, like you want to do multiple fenestrations into the superior mesenteric, celiac, renal. If you do a fenestrated grafting, then antiplatelets is mandatory. But for a routine thoracic or a routine Tripoli, you don't require an antiplatelet. You go by the risk of the patient also. The comorbidity side.
That is from Avinash Kumar, but one more question is asked. Do you use IBIS in cases of dissection treatment?
I don't have an IBIS with me, so I don't use it, but that is a very, very good modality. In fact, IBIS can be done either from the venous through the IVC also to look at the portions below, and IBIS also can be used, but I don't have any experience of using IBIS.
Santosh is asking, good evening, sir. Can you kindly explain the procedure steps details once for the new fellow IRs? Thank you.
Okay, I think I'll have to go back to the presentation. I can go step by step show in the cartoon itself. I can do at the end if there are any other questions.
I don't think there are any more questions, but there is some on the chat. Yeah. 1 second.
I think Dr. Dolly is here in the panelist. She can herself speak on whatever she wants. Dr. Dolly.
Dolly?
We can't hear you. I think.
In the meanwhile, I'll ask the question. 1 second. In my small experience with Dr. Michael Dake, Stanford, USA, we follow the rule that in case of usage of two stents, deploy the one with the smaller diameter first, and then the bigger diameter for a better seal. Additionally, if two stents of the same diameter are used, deploy the proximal one first and then the distal.
I think that's what we do always.
Yeah.
So when we, for example, this case, what I showed.
And they said area of overlap approximately 5 centimeters recommended.
Yeah, so that's what I told, at least 3 stents. Because 5 centimeter, it depends on the device what you are using. In the Cook device, we have a 2.2 centimeters. That means 2 stents straight is 4.4. If you have 3 stents, it is more than 5 centimeters.
I think no more questions, so you can.
Any questions from the YouTube, Dr. Jeet?
Yeah. So this is to answer this question. For example, that's what I told, which one to place first. So you look at the diameter. You will always see the abdominal diameter will be very less compared to the thoracic diameter. So in this case, what we do is we always take the distal device first, or the device, usually it will be the smaller one. You place this device first and be very careful. You should never lose control of the wire. So you get the wire nicely into the ascending aorta, allow it to coil nicely, and then place the distal device first. Through that, put the larger device so that the seal will be perfect. And you always look for 3 stent overlaps in the cath lab so that you'll have more than 5 centimeter of overlap. Now, coming to the procedure, I'll show the Tripoli, the cartoon itself. So the first step will be to, after you get the access, you're going to pass a wire, and this wire, you're going to take it up. Now you can see here, this renal artery is the higher level, this renal artery is at the lower level. So you're going to place the graft, the covered portion is going to start here. The bare portion will be a little bit above. So this will be the bare portion should be above, and you have to place the graft here. You have a landing zone of at least 15 millimeters. Okay. So with this in mind, so you always take the view in the cath lab where you will see the right renal artery the best. All these things can be decided on your CT, and the CT scan you take this particular view. Then you are going to take the graft inside. Sorry. So once you go there, now comes the next important step. Now, how do I map the renal arteries? There are multiple ways of doing it. Number one is you do an iotogram injection. The the cath lab table has to be perfect, and you mark where the renal artery is with the marker pen on your cath lab thing. Do not move the table. Lock the table perfectly, and then you take the stent. Then you start deploying here. So when you start deploying here, the first portion of the graft will never open fully. So it is just going to open this one. The first stent, when it opens, you just see. Do a check shoot. See that you are not above the renal artery at all. If it is above the renal artery, you can gently give a tug and pull it down. So many times what happens when you withdraw the graft, in the Medtronic, it is just by a rotation of the knob, it will come down, but it tends to slip back rapidly if you're not very careful. In the Cook, it is like the regular thing where you withdraw it with your hand movement. So you can completely control it step by step. And you see this, at this position, you stop and do a shoot. You are below the renal artery. Then you start opening it. So now you have opened 2 or 3 stents. The next thing is the opposite gate will have to open. So, yeah. So you can see here, this gate has opened. Okay, now the next step, what you want to do is, you can release the top cap straight away, now at this position. Or if you're confident, you can cross it and then release the top cap. If you're a beginner, what I will tell you is, you don't deploy the entire graft, you just, once this opposite limb opens up, again redo a check, you are below the renal artery, and then open the top cap. So the top cap is open, it will be perfect, it will nicely open up and sit there. Because once you open the top cap and it gets fixed, the graft will not move up and down. So you need not control at that time. So then what to do is, from here, from the opposite side, take a guide door with a catheter and try to get inside. You can use unique combination you want. Either you can use your RCA catheter with a thermo wire, or you can use Cobra or a RDC. See, in a small aneurysm, it is very easy to cannulate the opposite lip, very easy. Suppose the aneurysm is huge. Sometimes the gate will open somewhere here. You may not know whether it is anterior or posterior. You'll be struggling around for some time. In such a situation, it's always easy if you have a brachial access, get in a wire, come through this, pass through this graft very well, snare it out, and then do a railroad technique and do it off. So that is more easier. So don't struggle for a long time. So the next thing is, you see the opposite gate and then cannulate it. So that is what is being done. So once it is cannulated, they open the top gate here. Then you take the next device. So at this position, what you do is, you want to place the next graft. You have to do it above the interleak artery. So again, the next graft also has to be, the length has to be decided. Suppose if there is a junction zone here, from here to here, how much of overlap you want and how much of graft you want, up to the interleak artery you have to see. And then you have to deploy. You can always put in a marker pigtail and measure the distance again from here to here, and then you can deploy the second graft. So after that, in the Medtronic device, it's very simple. They have this aorta to one iliac, one device, and for the opposite iliac only, you need to add a second branch. But now they have got a 3-piece device also. Cook is always a 3-piece device. So once you place the third device, then we go and balloon all these things. One is the proximal zone here, the junctions here, and also the distal landing zone. You can do a gentle ballooning after doing a check angiogram, and the ballooning is done basically to remove all the crevices or the graft is smoothened to the wall of the aorta or the iliac arteries. Now coming to the thoracic, it is just the same technique only. You're just going to cross the aneurysm with your thermo guide wire. You're going to take the catheter, put in a stiff guide wire. Now, the stiff guide wire, the two important things is you want to place from here. The guide wire has to be in the ascending aorta. If you can get into the LV, it is good, but you don't need to go into the LV. If you get into the LV, sometimes a lot of arrhythmias will occur. So don't push into the LV. Come very well into the ascending aorta, your stiff wire. Then you pass the graft. When you pass the graft, the technical issue is when you are going to come across the curve, there will be a lot of resistance. Your assistant has to hold the wire very nicely, and then you go gently here, and then you go like this. Then again, you take the adequate oblique view. This can be a LAO 45 degree, LAO 60 degree. On your CT workstation, you can plan it, you can see it, and straight away do one shoot, you will see all the vessels very clearly, and where you want to land the graft. For example, here they're going to cover the subclavian. So again, the same technique of withdrawal. Sorry. So as they withdraw, the first graft, you open up and do a check shoot. The basic problem will come when you're going to come in this curve. That is the time the graft is going to move backwards. So there are some people, when they use the Medtronic device, they will tell, I'll move the device still forward because the device will come back so that it will align there. Sometimes it doesn't occur, then you will have to do an emergency plea. So what I do in my practice is be precise as much as possible. It takes a bit of time. When you're going to do this movement, the blood pressure has to be under control. So tell the anesthetist to slightly reduce the blood pressure and do it with a gentle movement. No need to panic. When you come back, when the device tries to move forward, you always can give a counter pressure and slowly deploy it, it will come in. There are some companies which tell, once you come here, do a rapid deployment. So you follow the company instructions, whichever device you're going to use. So then you can deploy the top end. The top end cap, it is the same release. Either it is a switch mechanism or a pull the wire according to the manufacturer. Does anybody else want to know anything here?
No, there is some other questions that have come now.
Okay.
I'm Dr. Endoleaks here.
Yes, sir.
Have you got any experience with Zenith Cook endografts?
Yeah, my maximum experience with the Zenith endografts only. I have not used Medtronic very much. Maybe I'll tell in my experience, 70% is Zenith endograft and maybe around 20 to 30% is the Medtronic and the other one, Lifetime.
Girish, have you got any experience with Zenith?
We started all with Zenith only, no? Then later on we came to Medtronic, and at one point there was even extruder, WL Gore.
Yeah, that's not available now.
Now Anaconda has come in. You have that other company which I have not used as yet. Which is that Murli?
That is
Bolton.
Jotec is just coming.
Yeah. Now Bolton has become Thermo already. Actually.
Yeah. One question is, sir, do you do fenestrations? How do you do fenestration? How to do fenestration? I think that is again another topic.
Another topic, I think we'll have to give
we'll explain that and show you all the steps also. But let me tell you, unless you do at least about 15 to 20 minimum of regular stent grafts, I would advise you not to go in for fenestration at the earliest, because it is a learning curve. Sometimes we see, if it is a custom made, it's a different issue. But if you are doing on table like a physician modified fenestration, then it is stressful. And the more the fenestration, more the problem. So I would not advise you to, at the start, do it. At least I would think 20 stent grafts you should do. What do you think, Murli?
I think so. Even now, if you tell fenestration, a surgeon modified, I always take 2 steps backward. I look at whether I can avoid it or not.
No, but sometimes it's unavoidable.
Unavoidable, then we do it, yeah. We try to do it 1 or 2 fenestrations and finish it off. Don't do multiple.
Okay, then one question, please tell about antibiotics in suspected infective aneurysms.
Okay. Infected aneurysms, the best treatment is surgical. If surgical is not possible due to some reasons, you have to put an endovascular graft. There are multiple things which you can do. Number 1 is the cultures are sent, and many times you may not get anything in the cultures. If you get something positive on the culture, treat the culture, involve your ID specialist, and put a PICC line for the patient and put them on a long-term antibiotic therapy. For the IV antibiotics, will have to go for at least 4 to 6 weeks. It is like treating the infective endocarditis. Then after that, the patients are kept on oral antibiotics for a couple of months. So this is the antibiotic protocol which we do for infected aneurysms. The second thing which we do is, sometimes we get patients, had some procedures done. They come with reinfection, where a complete surgical procedure will not be possible. In such a situation, again, put them on the proper antibiotics before the procedure for at least 4 or 5 days, then do the procedure. Then the surgeon opens up that portion and puts the momentum on the infected area also, so that the graft also doesn't get infected. So infected area managing is a complex thing. It's a nightmare. It is not very easy. So I think it involves a very, very meticulous planning and a very good teamwork.
Absolutely. And I would suggest you should not be treating mycotic aneurysms at all. Right. Only time you would treat it is in case the patient has ruptured, you don't have the time, you don't have the facilities for surgery. Then in those circumstances, and that has to be explained to the patient and the relatives, that you are doing this as a stopgap. Right. And as soon as you can stabilize him, you should be taking him for surgery. Yeah, Indu.
I would request you to do, sometime later, management of endoleaks.
Yeah. We are going to do that. And that's an important topic, and which is also challenging, but can be managed. I think we'll do that, but I think we'll put it in gaps, because otherwise we start doing aorta, people will get sick of it. So we'll go step by step, and then first I think we'll take fenestration, then we can take up endoleaks after that.
Yeah, not immediately, of course.
Yeah. There is another question for you, Murli.
Yeah.
Sir, how do you manage static obstruction of branch vessels in case of aortic dissection?
Okay. In aortic dissection, the most important thing is the entry point. If you cover the entry point, you would have sorted out most of the issues in acute dissections. Still, if you see some of these branches are getting obstructed, then you come down, try to cannulate the graft and put additional bare stents or a stent graft into those branches which are getting obstructed. But what we have seen is, we can show some examples also. It's not in this presentation. The moment you close the top, all the other things will open out, especially in acute stage. So, but we have to be very careful once we finish the procedure. If you had a renal obstruction or a mesenteric obstruction pre-op, at the end of the procedure, do an injection to the true lumen and check for good flow into these vessels. If you see an obstruction, you can always cross it and put a stent graft or a bare stent at least.
There's another question. Can you please, no, 1 minute. Can you please explain the additional modification / steps when the AAA extends to involve the bilateral, common, and internal and external iliac arteries?
Okay. I think number one is we don't want to cover both the internal iliac arteries. Number one. Number two is, if you want to cover one internal iliac artery, the best thing is you have to put some coils into the internal iliac artery or a plug into the proximal internal iliac artery so that there is no endoleak through the internal iliac artery when you want to extend it to the external iliac. So that is number one. If you have to cover both sides, I would suggest, yes, there are people who have covered it. They tell nothing happens. But you look at the literature, the risk of pelvic ischemia, the risk of the gluteal ischemia, sometimes the risk of pelvic organ ischemia is very high when you cover both the internal iliac arteries. So it is always better you preserve one internal iliac artery. If you have to preserve it, then you have to use the iliac branch device. And that itself is a separate topic. You have to use, maybe if you can, I can show the cartoon or it has to come from another presentation. We can use the branch device.
I think we'll go to the complex.
Yeah, complex will be a separate topic. I think
that we can include that.
Yeah,
whether you do a fenestration, we're talking about iliac branch device, reverse chimney.
Yeah.
Sir, one more question from my side. In younger patients like 40, 45 years who come with aortic aneurysms, have they experienced any erectile dysfunctions following the therapy?
Younger patients, can I answer that, Murli?
Yeah.
See, younger patients, I would advise that the patient goes for open surgical repair, because long-term patency follow-up is an issue when we are doing endovascular. So my first choice, if it's a young patient, first of all, if it is a young patient, then you have to consider something like aortoarteritis or something like that, resulting in aortic aneurysms. Even if it is not, maybe there is a juvenile atherosclerosis or whatever. Then in those circumstances, I think it is wiser that one goes for aortic surgical repair, and the results are time tested, and it's better that way. What do you think, Murli?
I think the younger patients, we hardly do stent grafts nowadays. Most of them get operated. I think what you told is correct. I think I accept your opinion on this.
But usually they don't come with, even if we are doing slightly older patients, they don't have erectile dysfunction as long as you do not cover the bilateral internal iliac.
Yeah.
But if you don't cover bilateral internal iliacs, then I up to now I have not seen.
Even I have not seen any patients with. You have read in the literature.
Because this is something, when they come for follow-up, they will definitely tell you.
Yeah, in fact, we had one patient who persistently was saying that he is weak. Then later on we realized that he was talking about erectile dysfunction.
Oh, okay. But the internal iliacs were not covered, no?
No, it was not covered.
So it's unlikely otherwise. I mean, there may be other factors causing it. We don't know. I think the questions are over.
Dr. Ajit, any questions from Facebook side? YouTube, sorry. You're muted. Please unmute you.
So there is only two questions. One is how to preserve spinal vascular supply. I think already answered by Dr. Murli. And second by Dr. Shivaji Poli, is there is endovascular treatment for ascending aortic aneurysm?
That is coming. That is coming.
That is now done in very few centers across the world.
Yeah.
Till they publish the results, nobody is going to give the graft to us.
Yeah.
But we have done for 2 patients. Maybe Girish also would have done. These are all patients who have had a coronary done. They have had a pseudoaneurysm. Where you put short grafts when they are not fit for open surgery. So right now, don't try all this ascending aortic at this point of time. They are all very tough things.
It's called an endobental.
Endobental, yeah. That is
so that is the new graft coming, but that's all in trial and everything. But it will take some time. There is another question. Hi, sir. Does your choice of distal landing graft change in acute or chronic dissection? 6 months old. As I understand, true lumen may not fully expand.
I don't think so, because now when you look at all the grafts, they're all the nitinol based only. I think whatever is the material, the graft expansion is going to be similar. Previously, stainless steel, yes, stainless steel versus nitinol people used to discuss. Now the Cook company also shifting to nitinol. Other companies are also on nitinol base. I think more or less it is similar. I don't have a choice of using this graft for something and that graft for another thing. I don't look like. Do you have anything like that, Girish?
Yeah, I'll explain that a little bit. But what he's asking is any choice for distal landing graft change in acute and chronic dissection. Means where do you land the graft? That's what he's asking.
Okay. I see.
In acute and chronic, is there any difference?
I don't think so. You have to land the graft where the graft has to align nicely with the alignment of the blood vessel. If there is a kink, don't land in the kink. Come to the straight portion and land the distal end of the graft. That's all. So that you have to look at the long-term outcome. You don't put in a curve. You come in the straight portion and deploy the graft. That's what I mean.
And you have to have significant length below the aneurysm segment.
Aneurysms, yes.
Yeah, one problem we have faced, and it's currently is asymptomatic. But when we have done a candy plug, now we've used a Medtronic graft for the main dissection, and we've used a Cook graft for the candy plug.
Okay.
When the patient has come for follow-up after 6 months, the candy plug graft is the one which has actually kind of compressed the main graft. And that's why the lumen is become much smaller, but there is flow. So now the question is whether to treat this patient and put say a balloon mounted stent in the graft, the main graft in the true lumen. The question is, do we do it or not? Since the patient otherwise is asymptomatic, does not have any postprandial pain, does not have any ischemia. In these circumstances, we said we will follow up after another 3 months and see if it is further diminishing or the symptoms come, then we may be compelled to do it. Again, now to explain to the juniors what is a candy plug, we'll do it in the complex case discussion. But which I was very funny to see it, because both the grafts are the candy plug was a stainless steel, the Cook one, whereas the Medtronic was nitinol. So maybe that was the reason, we don't know.
Very hard to say. I think the question what they have put is change in acute or chronic dissection, choice of distal landing graft. By saying that, I think the question is directed towards the dissection stent, which is the bare stent available from the Cook, which they claim to put in the acute phase, basically covering the primary tear.
Talking about the petticoat concept.
Yeah, I think so. The question is directed to that, acute versus chronic, because the false lumen has expanded. I mean, I don't know. Lot of group don't even use that dissection stents nowadays, because there is a problem when you go for second stage for type B. So we have done a couple of times, but honestly, I mean, it's better to go with the covered one, even in the acute phase, as we do. So 2 covered stent grafts, or you have a long one from Bolton, like 250.
Hmm.
Yeah. So it's hardly used. I think just one was available last time when I did, like couple months ago. I asked the cook guy and he told like only one is available in the country. Nobody is using that bare dissection stents nowadays.
The problem is that that can precipitate further dissection.
Yeah, I mean, there's two school of thought. Some say
Correct.
like it's of no use. There are multiple tears, and then in future it causes more trouble. Yeah.
Correct. Where did Kamal Pata go?
Yeah, Girish, I'm here.
So you have anything to add? We can't see you.
Nah,
The video is off. Anyway, anything to add in that?
No. Excellent. I think President Murli covered up most of it.
Yeah, sir. Just regarding the spinal ischemia, there were many questions. So I think the institution practice differs. Now, at least at my place, I always put spinal drain in all the cases. We have burned our hand. In spite of, see, it's a bad day or what, I still remember two cases. One was really young chap with acute dissection, RTA. So there was basically a transaction came and then we placed just an 8 centimeter cook and he had a paraplegia. We didn't even cover subclavian. I don't recollect now, but that was one case. And then there was one more. So now we have made a protocol. We place spinal drain in all. And out of that, two cases I have seen like, and the drain, what we do is it's not like a non-continuous, it's a continuous drain. We keep the pressure at 10 or less throughout the procedure. And prednisone, as Dr. Murli has covered everything. I mean, it's institutional difference. If you have burned your hand, you're, more safer. So now the thing is, we always place, and we have seen that day 2. So we don't pull out the drain. We'll clamp it, ask the patient to move his movement. So twice I have seen, once you clamp your drain, the weakness starts. So you keep it for a couple of days, keep him on steroids, and then slowly taper off. So it's very helpful. Still, I would say, the 5%, which is which we explain to our patients, is still there. And it again depends on the institutional practice. So we always place spinal drain. It's a protocol now for TIVAR. Even I'm doing an 8 centimeter, there could be a bad day.
But I think, Viru, that is a overkill. I personally feel.
But what is the loss?
No, but there are instances of keeping the spinal drain for a longer period of time, having infection and infection.
It is not only infection. Some people have developed spinal hematomas. The technique is not good. It's a technical issue, right?
Yeah, I think it's a debate, but I think losing leg, patient is
that's again worse.
So it's again a debate. I agree, but now we have made a protocol. Everybody is so well trained, so we take care of everything, right? Possibility is always there. So even when I flew Indore for 5-7 times, even the neuroradiologist, the neuroanesthetist comes over there and then he places a drain. Everything is ready. So now we have made basically a habit. We encountered 2 patients, and the young patient, looking at him paraplegic for whole life. It was really so. I usually place.
Because I have done so many now. Only in about 6 months ago, I got a patient with paraplegia. Now, I don't know what the cause was. I anticipate is that basically the false lumen was not that big. And that's why we managed to seal off the entire false lumen. And because of that, because there was no re-entry and it was not filling up the false lumen, maybe that is the reason why I caused it. Possible.
I think I had seen one patient 6 months back. It was thoracic aneurysm, straightforward, no subclavian coverage. And we finished the procedure. Patient was fine. He was in ICU for a day. Second day, he went to the ward. Third day, he developed paraplegia.
Third day?
Yeah, third day, he developed paraplegia. Yeah. And you won't believe this patient, he listened to all the complications. He just told before getting induced, doctor, I will never lose my limbs, no?
Oh my God.
I never knew why he told it. It was like a premonition from him. I told nothing will happen, everything is fine. Then second day I told, see, you're moving your legs, you're all right, don't be worried. The next day he developed paraplegia. So what we did in this patient was immediately put a spinal drain after that, kept it for 48 hours, put him on a high dose methylprednisolone therapy for 5 days. Now the problem is the cardiac surgeon asks for the neurologist. The neurologist comes and writes there is no role for methylprednisolone to treat such things. And the intensive care guys will not give the drug. Then I told them, you give it off. We do it in the neuro. Let her give it off. We gave it. No harm will be created. Then finally this patient recovered. Luckily he recovered after 2 days. He got back. Now he has got some mild residual paralysis, but he's all right. But the only thing I found was, what had happened was, when he was in the ICU, the blood pressure chart was perfect. When he went into the ward, I think in one of the blood pressures crashed too. He was always having a pressure of 160 to 150. And there was 2 readings of 90 by 60, 90 by 60. So we don't know what caused that. Then after that, we told stop all the antihypertensives, let him be at high pressure. Then we slowly taper it. We don't want his pressures now to reduce below 150.
Yeah. The same thing has happened in my case, that he had a bout of hypotension.
Yes.
But my stent graft was not very long at all. It must have been maximum 15, max.
Yeah, sir, I'm telling you, it's like sometimes if the major artery goes away, I am telling you that young chap, it was 8 or 10, I don't remember, transaction case, and I mean he was paraplegic with a small stent graft. Even the cook rep told me once he was doing somewhere he didn't name, with an 8 centimeter cardiology colleague was doing, and patient was paraplegic. So it can happen. And the other thing with Dr. Murli, so Dr. Murli is saying like they placed a spinal drain. I have seen that. We had done a thoracic, and it's like initially when there was no protocol, yaar chodo na, kaun dalega, it will take time. The anesthesia kills like an hour putting drains when they were not trained. So we just left it, and we did a thoracic, went well. Patient was moving leg. We went for our dinner, and within an hour we got a call that the leg movements are going, and then it becomes a mess putting. You have given an anticoagulation and all that. So now it's not easy, but they placed a drain and he recovered. So it has a role, and now we have made a protocol. So I don't know whether it's an overkill or not.
Of course, spinal drain has a role. There's no doubt about it.
Yeah, but hemodynamics is also.
But to say that every patient to do it,
sir, it's a protocol now. So I mean, you don't break your protocol. So now the thing is, Stephen Olan, he says 3 things. So pressure 10 or less. Then he says hemoglobin more than 12 and systolic more than 120. So these are like 3 things. And then maybe role of steroids. So we give an hour before methylprednisolone. I mean, we never know. In spite of doing all this, patient can have. Yeah. So it's just like,
No, but now, for example, what if your protocol you follow, like Murli just said, you remove it after 24 hours.
48 hours.
So we clamp it. No, we try within 24 hours. So next day we'll clamp it. For 6 hours, I'll clamp it. Before shifting from ICU to the ward, so early morning, when I go for a round, I clamp it. I see for 6 hours. So by the time the room arrange kar rahe, sab kuch, it takes 6 hours. If there is nothing wrong, then my fellow will pull out after 6-8 hours, and then I'll shift to room. So next day we remove. But I mean, if we are unfortunate, can happen 3rd day and all that. But try to keep hemodynamics, pressure high, and all that. Yeah. Good hemoglobin. He even says.
And then the hemoglobin. Blood loss should not be there. You have to see that you replace the blood loss.
So what are the 3 criteria you said?
Sir, he follows 3 things. He says HB more than 12.
It should be more than 12.
Yes. And then he says blood pressure systolic 120 plus and spinal pressure less than 10. The 3 things he says, I mean, are important. And then definitely they follow celiac should not be covered. Internal iliac should be patent, because Tara Maastricht presented a case at that meeting. She says her actually patient was TVAR plus they did all that CMD. So they had covered till all internal, external iliacs. And then the patient's internal iliac was stenotic. So what happened was, when they clamped the drain, the patient went into basically paraplegia. When they released, the movement started coming back. So she did a run, and then she saw that there was a stenosis in the internal iliac bilateral. So they had to plasty and stent, and after that, I mean, when they clamped, there was no pressure. So the spinal flow can come from anywhere. So they try to preserve as much vessel as Dr. Murli told. Try to preserve the internal celiacs, whatever you can. the subclavian. So the collaterals can come from anywhere.
See,
No, of course. It can come from vertebral also.
Yeah. See, the other important thing is you do all these things. Always you watch the patient very closely. You can always put a spinal drain later also if you're not using it as a protocol.
No, but
I think I have seen a paper. I'll send you that review paper.
What he's saying is that you have given anticoagulants and then...
I know that. These are all the issues. Because you would have heparinized him and then you're worried about putting in a drain. All these things are there. So, but I think I'll send the paper. It was a huge review paper. The recommendations are just coming in. Whether we are overkilling it. I just read it recently. I'll just share that paper. I think we'll put in the group. The ISVIR group. I think I'll get that paper.
Yes, sir. Yes, sir. So I think, sir, next after few lectures on liver or something like taste here, I think Dr. Girish and Dr. Murli can present on the physician-made fenestration. That will be nice.
Okay. No problem.
Thank you, Dr. Murli. It was a wonderful presentation.
Yeah.
And I would say that you are a gem for ISVIR and will utilize you more often.
Thank you. Thank you. It's a pleasure meeting all of you. Couldn't meet in Goa at least. This is good.
Yeah.
Thank you, sir. Thank you. So by this, we end this meeting and we'll inform you about the next webinar. It will be on the Friday. The topic possibly will be sent to you by tomorrow. Thank you all.
Thank you, doctor. Thank you, sir.
Thanks.
Thank you. Bye. Bye.